Hi, good evening.
Have a great meeting. Good evening, Molly.
Hello, good evening.
Have a great meeting.
Thank you.
This is the clerk with a courtesy announcement that the meeting is now live on the internet.
Good evening, Megan.
Good evening.
Have a great meeting.
Thank you.
Good evening, Supervisor Chavez.
Rhonda, I'm having some trouble with my audio. Can you hear me?
I sure can.
Okay.
Hey, Rhonda, it's Cindy. Can you hear okay?
Yes, ma'am. Thank you very much.
Thanks, Rhonda.
Have a great meeting.
Rhonda, can I try once more?
You sure can.
Thank you.
Supervisor Chavez, just FYI, your camera is blocked. I'm not sure if you even knew it was on. There you go. Now we can see you.
Thank you, Rhonda.
My pleasure.
Oh.
Recording in progress.
Hi, Rhonda.
Well, you snuck right in there. Hello, President Wasserman.
I did.
And we also have Supervisors Committee in here.
Yes, we've got, the team is here.
The team is here. Your clerk this evening is going to be the lovely Peggy Doyle.
Right on. 6 o'clock. Thank you, Rhonda. Goodbye. Peggy, roll call, please.
Supervisor Lee,
Lee present.
Supervisor Chavez. You are muted.
Thank you, Peggy. Yes, I'm present.
Supervisor Simitian,
Here.
Vice President Ellenberg,
I'm here.
and President Wasserman.
There as well. Thank you. We'll have Vice President Ellenberg lead us in the Pledge of Allegiance. For all that can, please stand. Vice President.
I pledge allegiance to the flag
flag
of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Thank you very much. With that, we'll move on to public comment, item number 3, which is the opportunity for anyone to speak about any issue not on today's agenda. So any issue not dealing with behavioral health for the most part. And we'll give them just another 30 seconds for anybody who wishes to register electronically so they can be recognized to speak. All right, Rhonda, let's go with 2 minutes each.
One moment while we set up the timer.
Thank you.
We should also give you a forewarning that Google Timer is no longer in existence, so we will be using a new timer system today.
Thank you.
Our first speaker is Linda Edwards. I'm unmuting you. Please accept the unmute to begin speaking.
Good evening, everyone. My name is Linda Edwards, and I'm with the Common Sense to Save Our County Coalition. I live and vote in District 3. For 2 years, we've been subjected to your lockdowns and mandates, which have negatively impacted our day-to-day lives in numerous ways. Countless people in our county have lost their jobs as a direct result of your mandates. Businesses have gone under as a direct result of your mandates. Children have lost valuable learning time in school as a direct result of your mandates. Suicides, depression, and substance abuse have increased as a direct result of your mandates. We say no more. The pandemic has run its course and is now endemic. We must learn to live with it like we do a common cold or flu. We demand that all mandates be removed immediately and all county employees that were fired over mandates be reinstated. We say no more mandates. On a personal setting, 3 of my personal gal friends have lost their jobs as a direct result of your mandates over the last 2 years. 2 of them were hairstylists with careers that spanned up to 50 years. One is Latina, and she is in her 70s. She was supporting herself with being a hairdresser for 5 decades. But because of the constant lockdowns, she lost her businesses, her clientele, and no longer can work supporting herself full time as a hairstylist. Same with another girlfriend who was a hairstylist. A third girlfriend used to work at the San Jose Tech Museum, and she was downsized because of the never-ending lockdowns for the Tech Museum. It's very sad to see what has happened over the last 2 years. I know you guys are very proud of your national leadership as far as vaccination rates go, but every single percentage point equates to businesses that have gone under and people who have lost their jobs. And you need to be aware that now that we're reopening, we need to do it immediately, and we need to do it consistently with the state of California rescinding their mandates also. So please, we shut down with clear information.
All right, thank you.
Our next speaker is Laura Champion. Please accept the unmute to begin.
Oh, good evening, supervisors and county leadership. It's so good to see all of you. My name is Laura Champion. I'm a consultant and a marriage and family therapist, and likely you remember when I was executive director over at Uplift. I have the privilege of consulting for the Healthier Kids Foundation school-based mental wellness screening project. It's in its 2nd year and the outcomes are impressive. I'm concerned because I'm not seeing that this prevention model is fully funded. And it is endorsed, this model is endorsed and recommended at the federal level, particularly through the Families First Prevention Services Act. Being directly involved with it, I'm seeing that not only are children being encouraged to express their worries and concerns at school and having those addressed, but they're also helping their families to get basic needs met. So I'm requesting again, I've been here before, I'm requesting again that this project with excellent proven outcomes be fully funded. It's an alignment at the federal level, and it's an excellent addition to the dental, vision, and hearing screenings that Healthier Kids Foundation has been doing for quite a long time. And the collaboration with the school districts, behavioral health, and community-based organizations is pretty impressive. So again, I respectfully ask that you consider fully funding this. It's not a tremendous amount of money, and it's netting excellent outcomes. So thank you very much. Thank you for your service. Have a great evening.
Thanks, Laura.
Our next speaker is Kathleen King. Please accept the unmute to begin speaking.
Hi, I'm Kathleen King from Healthier Kids Foundation, and I apologize. I told those that we work with that they should speak in the public input because we're not on the agenda, so I hope that's all right. I want to thank you for your support. We have offered over 56,000 services this year, especially in vision, dental, and hearing, and My Health First. And echo what Laura Champion has said, that we think this universal approach to screening children is the way to find the children that really need the help that aren't always obvious. We think it works well with the previous Project Cornerstone work, and we use some of the Project Cornerstone questions in the work we do because that also was a universal screening program. We've been told by the schools that they found children they didn't expect to find, and we just like to branch out to as many children as we can. For every dollar behavioral health is funding, we have to raise $3. And I have to tell you, I don't feel that's the best use of my skills. I rather expand the program than be spending so much time on fundraising. So just want to thank you. I think none of this could happen without schooling services. And I want to thank you for the schooling service approach to everything because we just couldn't do what we're doing without it. So thank you.
Thank you, Kathleen. And speaking now just means not speaking later. So I appreciate your acknowledging that. Thank you.
Our next speaker is Paula Maddox. Please accept the unmute to begin.
Good evening, everyone. My name is Paula Maddox, and I'm with the Common Sense to Save Our County Coalition. I live and vote in District 5. For 2 years, we've been subjected to your lockdowns and mandates, which have negatively impacted our day-to-day lives in numerous ways. Countless people in our county have lost their jobs as a direct result of your mandates. Businesses have gone under, children have lost valuable learning time in school, and substance abuse has increased, as well as domestic violence, all because of these mandates. We say no more. The pandemic has run its course, and now it's endemic. We must learn to live with it like a common flu or cold. We demand all mandates be removed immediately, and all county employees who were fired or mandates be reinstated. We say no more mandates. Currently working with some of the population in Santa Clara County. I have worked with some of the homeless. One particular client has not been able to get services because his doctor indicated he could not have the COVID-19 vaccine. He remains homeless. He cannot get into any programs that mandate vaccines. I've had clients who cannot get jobs because they too cannot get vaccinated for whatever medical reasons. This has been a struggle for some of the people out in our county who want to get on their feet and do better, but yet they're being limited because of a medical treatment that, in my opinion, we need to stop and now allow these people to try to do better for themselves. And the only way to do that is to look at the science and look at the mandates and get rid of them so that people can move forward and have happy and healthy lives. Thank you very much.
Thank you.
Our next speaker is Chris Ingram. Please accept the unmute to begin.
Good evening. My name is Chris Ingram, and I'm the director of the Program Development at Healthier Kids Foundation. And I want to echo Laura Champion and Kathleen King in thanking you, the board, for your support of behavioral health services and continuum of care, which are so critical to our youth and families at this time. Healthier Kids Foundation has been conducting emotional wellness checks among fifth graders in Santa Clara County. Of the 1,950 students we've screened this school year, 47% have been identified as having unmet emotional and mental health needs, with 3% being in imminent risk. Let that sink in for a moment. Almost half of screened students have unmet emotional and mental health needs. Healthier Kids Foundation parent advocates follow up with the parents of these students to assist them in obtaining supportive services for their children. Parents and families are struggling both to support their children and themselves. Thank you for working diligently to make resources available and accessible to our families. Thank you for your time today.
Thank you.
Our next speaker is Brenda Salazar. Please accept the unmute to begin.
Hi, thank you, supervisors and county leadership. My name is Brenda Salazar, and I'm a licensed clinical social worker in the Student Wellness and Support Services Department in the Franklin McKinley School District. The pandemic has had a significant impact on our school community, as our district has some of the highest COVID rates in the county. This year, our district has been intentional about focusing on the well-being of our school community to include staff, students, and families. Our district has focused on school safety, connectedness, and belonging. Students and families have experienced many challenges during the pandemic, and many have requested counseling support. Our team of school social workers have worked closely with community partners to provide support to families in need of services. Our MOUs with County Behavioral Health and the Healthier Kids Foundation have supported our efforts district-wide. I would like to highlight in particular our partnership with the Healthier Kids Foundation and the My Health First program. This program was piloted in the 2021 school year and continued this year. The program targets all fifth grade students and identifies supports that the student and family might need, including mental health counseling and other community resources. This innovative program is important to our district, and we look forward to expanding the program to reach other students. Thank you.
Thank you.
Our next speaker is Irvish. Please accept the unmute to begin.
Thank you very much to Board of Supervisors, respective chair, vice chair, and the rest of the Board of the Supervisor. I want to emphasize on some of the challenges that what Santa Clara County has been going through and would require to address. As the County of Santa Clara improving the behavioral health and mental health resources along with the COVID-19 situation, it is important that, what we bring from pandemic to endemic, what becomes important is to address that, what has not been implemented. When any particular bill, whether regardless of a Senate bill or Assembly bill that gets implemented, in order to take that effective, it takes about a year for a bill to be implemented, executed, and verifying that, whether the effectiveness of that bill and ordinances within the County of Santa Clara works or not. Also to ensure that as a more and more enhancement and the work adoption is being done, it is equally important to verify the sections of such as well. Equally, not all with the diversification of a County of Santa Clara, it is important that some of the work that is being carried out also require the language interpretation. Not all diversified public speaking as well as the resources being aligned for the special facilitation purposes with the language interpretation as well. For example, the Spanish speaking people. Also to ensure that along with there are certain facilities specifically for veterans, if they were to take any resources or any health resources, they have to travel all the way to Palo Alto for the VA clinic. There are specific resources that require to be addressed for specific people within the County of Santa Clara. So I request that that is something be brought up to Board of Supervisor with the veterans.
Our next speaker is Katherine Hedges. Please accept the unmute to begin.
Thank you. First of all, I'd like to say that as a person with multiple high-risk conditions for COVID, I know that a large percentage of the population has at least one high-risk condition. And, you know, I'm just boggled that people's lives are not worth as much as business, and that everyone says to just reopen and let everything go. And people with disabilities are going to die of COVID or have long-term consequences that make them even more disabled. And, you know, and I don't feel safe going out in public after the mask mandate is removed. And I don't know what things, is there going to be more public comment for the things in the report, or is this only chance for public comment?
This is the only chance for public comment, Catherine.
Yeah, I'm really concerned that our mental health services don't provide enough services. That you can't get somebody, if somebody is having a significant problem, but they're not actively threatening themselves or others, there is nobody that will respond to that except the police. And we already know there's a high probability the police are going to shoot them if they don't, you know, get on the ground and comply or whatever. And I have a neighbor who's threatening me. Well, not threatening me, but he's just saying like threatening kinds of things like get out and you don't belong here. And he's hostile, but it's not an actual threat. And he's, you know, punching holes in walls and slamming doors. And I don't feel really safe, but it's not something I should be calling the police over either. And there's nothing else that I'd have.
Thank you.
Our next speaker is Anya Artigas. Please accept the unmute to begin.
Good evening, supervisors and county leadership. My name is Anya Artigas, and I work for Alum Rock School District as a coordinator of mental wellness support services. As we've navigated the last several years of living in a pandemic, partnerships with county-funded mental health organizations, schooling services, and the Healthier Kids Foundation have allowed us to serve the children and families of Alum Rock School District. The partnerships have allowed us to serve and support in real time with appropriately leveled resources. They've allowed us to address, assess, and identify students and families in need of layered supports. Conducting these universal screenings across our fifth grade population of students provided my district with the opportunity to begin to more deeply understand the experiences our students have had and connect them with the supports they so desperately needed. Thank you for supporting our students and families during such challenging times through your continued support of these necessary programs. Please do consider funding the Healthier Kids Foundation. Doing these screenings are integral for our students and integral for their wellness. Partnerships like this make it so that we're able to support more and more of our students as they need it. Thank you so much.
Thank you, Anya.
Our next speaker is Kamakariku. Please accept the unmute to begin.
Good evening, Board of Supervisors. My name is Kamala. I am a clinician on the Mobile Crisis Response Team. I apologize if you hear my baby in the background. So I just wanted to bring to your attention that we are a team of only 10 clinicians at the moment. We are a very short staff team. I know that you have worked so hard to expand our codes, but we are continuing to just be short staffed. And it is my understanding that we are also short staffed in the whole behavioral health department. So I am just bringing it to your attention that, you know, maybe you can work with the management closely or, you know, give them a heads up or something. I don't know. To, you know, bring more hiring and, you know, plan strategically so we can have more staff, because there is a lot of pressure on each of us. And there's also a community need, and we have to keep continuing to provide our mental health services because we all know how important that is. So I just wanted to like bring it to your attention.
Thank you very much.
Thanks.
And that concludes our speakers.
And thank you very much, Peggy. I appreciate that. I thank all of our speakers that participated today. We now move on to item number 4, which is under advisement from the December 7th, 2021 meeting. We are to receive a report from the Behavioral Health Services Department relating to the behavioral health continuum of care that exists in Santa Clara County. Is Sherry there? Sherry. Hello, Sherry. Good evening.
Hi, good evening, President Wasserman and members of the Board of Supervisors, Sherry Terrell, Director.
with our Behavioral Health Services Department. We wanted to thank you for the opportunity to hold this workshop focused on our behavioral health system. And I think as we get started, I was just hoping to kind of quickly go through the agenda, and then we will go ahead and get started. We're going to go ahead and get started with Dr. Smith, who will provide an introduction and history of the public mental health system, followed by Aurora Health Group, who will be presenting on the county behavioral health responsibilities under federal Medicaid, county behavioral health funding, and state efforts around California advancing and innovating Medi-Cal or CalAIM. And from Aurora Health Group, we have Molly Brazel, a vice president, and Don Kingdon, a strategic partner with Aurora, who will be presenting tonight. Following Dr. Smith and Aurora Health Group's presentation, we will have an opportunity for Q&A, as Aurora Health Group will not be able to stay for the full workshop. So following the two presentations, we'll pause for questions from the board. Following that section, we will then transition into the presentation by the Behavioral Health Services Department that will focus on the behavioral health continuum and our strategic objectives. And we'll close the evening's presentation with Elisa Koff-Ginsburg from the Behavioral Health Contractors Association, who will present on workforce strategies. So that's going to be how we'll move forward this evening. And with that, I will go ahead and introduce Dr. Jeff Smith, our county CEO, who will take us through the next part of our presentation.
Thank you, Sherry. Doctor.
Thank you, Sherry. Let me share. I've got 5 slides I want to show you. And I asked Sherry to allow me to start off here because I wanted to give a little bit of context of the public mental health system in California. Today, you're going to hear a lot of details, a lot of different programs, a lot of discussion about how a system works. And for the most part, most people who study this start off with a lot of confusion. And the confusion, in my opinion, is because we're a victim of the past. And this system was not created, it grew. And it grew out of a lot of strange conditions. So I'm talking about the public health system, which is distinguished from the private system, which grew up in a similar way, but not exactly the same way. And I'm also talking about the adult system of care, not children's system of care, which came later and was grown in a different way. So starting back in the Middle Ages, the treatment for people who had behavioral disorders that couldn't fit in was an asylum or a psychiatric hospital. In California, the first psychiatric hospital started in 1851, a year after we became a state. And essentially, they were warehouses where people who didn't fit into society for behavioral reasons were housed. There was very little treatment. As a matter of fact, there were oftentimes lots of mistreatment and torture that occurred. And in order to be placed in a state hospital, you only needed to have 2 doctors see you and 1 judge decide that you needed to be committed, and you could be committed forever. Now, in terms of the numbers in state hospitals, at the peak in California, which was about 1955, there were 37,000 citizens in state hospitals across the state. At that time, the population was about 13 million. So that means about 3% of the population was incarcerated in a state hospital. Now, we know right now that severely mentally ill adults account for about 4% of their general population, no matter what community you're in. And in general, about 16% of the population has some mental illness. So we're talking more about severely mentally ill right now than the moderate or minimally mentally ill. And you can see how the treatment system in California evolved. The first 5 pictures at the top, starting back in 1851, are hospitals that were created. So first there was Stockton, then Napa, then Agnew State, then Mendocino, then Patton State. Notice that all of these hospitals were at the time, rural areas, far from the population. The basic theme was to keep people isolated from the population. Then in the second line, you'll see that in 36 was the first lobotomy that was performed in a state hospital in California. This was a vicious kind of surgery where you basically scrambled the frontal lobes of an individual patient, and they became more compliant because they lost their personality. As a matter of fact, in our current Lenzen building in San Jose, it used to be a hospital, and the last lobotomy in California was performed in that hospital many, many years ago. The next picture is a picture of Camarillo State. And then the middle picture is showing insulin shock therapy. One of the ways that people tried to control mentally ill individuals is to give them an overdose of insulin, which caused a seizure and temporarily made them act more sedate. Then in 1944 was the first use of electroconvulsive therapy in California. Again, a way of giving them seizure and having them be more compliant. More hospitals in Modesto in 47. And then finally in 53, the first training for psychiatric techs. Up until then, so that's 100 years, the individuals who worked in the hospitals were untrained, unskilled, typically used power and force in order to control patients, oftentimes abuse patients in multiple ways. Finally, there was a realization that we needed to treat or train these people to treat mentally ill individuals. And then in 54, the first psychotherapeutic drug to be used for severely mentally ill individuals, that's Thorazine. Thorazine was, and still is, slightly equivalent to a chemical lobotomy in the sense that it makes the patient compliant, but it basically robs their cognitive participation in the activities that they're doing. And then in the 60s, late 60s, a couple of things happened. People began to realize that it wasn't a great idea to have mentally ill individuals locked up in state hospitals. They began to have hope with Thorazine and other chemicals that there might be a way to have them taken care of in the community safely. Medi-Cal and Short Doyle began to pay for care of severely mentally ill individuals. And there was what was called a carve-out, meaning that special funds were utilized for psychiatric care that were separate from medical care. At the time, it seemed like a great idea. You'll see over the years what it did was separate the type of care that you got. And then in 67, LPS law was passed, got implemented in 69. And basically, there was a changing understanding of mental illness. Over the years from 1850 to 1967, there were lots of different ways to talk about mental illness. People called it hysteria, neurosis, mania. Hydrotherapy was used, torturing people. They called idiocy for those individuals who were cognitively impaired. They used restraint and isolation therapy. Hebephrenia was the name for schizophrenia at the time. Remember, back in Freud's days, there was psychoanalysis. However, psychoanalysis only worked for mildly mentally ill individuals because it was focused on cognitive training. Didn't work for severely mentally ill very well. There was catatonia, which was untreated psychiatric illness. And terms like dementia precox were used, indicating that there was a realization that the brain was not working and it was happening earlier than normal. This was an early name for schizophrenia. But in '67, there was more understanding of mental illness and began to get structured in a different way diagnostically. In general, there are five categories of mental illness that lead sometimes to severe mental illness. There's a psychotic group, which is basically people who cannot perceive reality. They have hallucinations, delusions. Schizophrenia is in this group. Schizoaffective disorder is also in this group. A number of other processes in this group. Mood disorders are emotional instability, depression, anxiety, mania, and a number of other disorders. Anxiety is another group, problems with regulation of fear. Major anxiety disorder is the characteristic of this group. Then there's cognitive impairments, where there's impairment of learning capacity and developmental disabilities. And then a very important one is personality disorders. These are disorders where a person's individual way of behaving or thinking is persistently detrimental to their behavior and is characterized by some particular function. Probably the most common personality disorder that we hear about is borderline personality disorder, which is characterized by an inability to develop close relationships and functioning highly intellectually but difficultly emotionally. The problem is it's not that easy. Just having a diagnosis helps with the treatment, but oftentimes diagnoses are mixed up and it's very difficult to tell exactly what the cause of the disabling behavior is. Very many people who have major psychosis also have some personality disorder, and oftentimes they have substance abuse disorders. And since the brain and our minds are the only way that we communicate with each other, sometimes it's the single common denominator that leads people to have abnormal behaviors that are similar in different people with different diagnoses. So what we're talking about now is actually focused on not what the diagnosis is, but how disabling the behavior is that comes from the diagnosis. And you'll see that we're talking mostly about serious mental illness, which is defined there as a serious functional impairment that substantially interferes with your normal life. And when LPS Conservatorship Act was passed, this allowed for a different type of involuntary hold, a civil voluntary hold for individuals who were seriously medically or mentally ill. Rather than having 2 doctors examine them and a court putting them in a state hospital permanently, they were evaluated, and the criteria for being held involuntarily was that you were a danger to yourself, which really meant you had to be actively suicidal, or you're a danger to others, which meant you had to be homicidal, or gravely disabled, meaning you're unable to provide food, clothing, and shelter. And it had to be because of a mental illness. Being homeless alone was not a qualification for grave disability, and still is not. So we had lots of different competing priorities, which is why we have lots of confusion in the law and the way that severely mentally ill individuals are treated, not only in California, but throughout the nation. There's the debate between paternalism and partnership. Community-based organizations wanted to take care of people in a partnership, and that means that they would have to participate in their care. Traditional medical model was relied upon paternalism, where the doctor or the system knew better what you needed. But there was still a pressure to deinstitutionalize on both sides because institutions were very expensive and clearly didn't work. LPS was created in order to give the patient a voice in their treatment. So therefore, LPS law has an enormous amount of due process where the patient can challenge decisions by the doctor or by the system, and either challenge it in court or challenge it with an administrative judge. There was debate at the time in '67 between the medical model of mental health problems and the community model. Medical model meaning that just like any other disease, there was a dysfunction of the brain that could be treated. Community model focused more on the behavior that led to the concept of mental illness. And familiar here is Dr. Thomas Szasz, who wrote a book at the time putting down mental health diagnoses and arguing that mental health was a fantasy of a development problem in how you related to community. There were insufficient options for either treatment, and the interest at that time began to expand into moderate and mild illness, because at this point in the 60s, late 60s, was the first time that we had antidepressants, which were things like Elavil, and also we had depressants and treatments for anxiety like Valium. So we have a confusing system. It's hard to navigate for even those of us who understand it. It's really hard to navigate for those who are mentally ill. And I think the best summary of mental illness is something that is not a destination. Mental health is not a destination. It's a process. It's not how you drive, it's where you're going. I mean, it's not how you drive, it's about how you drive, not about where you're going. I'll get it right eventually. And we're looking at this point in our history to reorganize our mental health system, to rethink how it functions. There's a big push now to integrate mental health and medical health to make sure there's equity among the two, and to use all tools that are available to help. But we still have problems, we still have challenges, and we still have lots of people who are severely mentally ill. So with that, I will turn it back to Sherry.
Thank you very much, Dr. Smith. Appreciate that. Sherry, we move on to item A, the first item, the report on the continuum of care.
Yeah, so it's, I'm pleased to introduce Molly Braswell and Don Kingdon from Aurora Health Group, who will present a snapshot of California's county behavioral health system.
Great, thank you, Sherry, and good evening, President and members of the board. So we have been asked by Behavioral Health Services to offer context for the important conversations that you all are having related to the county behavioral health system. We've been asked to provide a brief snapshot, if you will, of the primary programmatic responsibilities that fall under county behavioral health, the key governing authorities, and key financing structures and implications. Just to say, we're going to put a lot of complexity into just a handful of slides here and try to keep our piece to, I think, 10 to 15 minutes. So just to say, snapshot is a strong word. I will walk us through a short series of slides, and then my colleague Don Kingdon, who's a senior strategic partner with our team, will lead the Q&A portion for our item. Next slide. Great. So we have organized tonight's presentation on the scope of county behavioral health responsibilities into 3 categories. First, we have responsibilities under the federal Medicaid program. So these include Medi-Cal specialty mental health services and Medi-Cal substance use disorder or addiction treatment services. This program is also known as the Drug Medi-Cal program. Second, we have responsibilities under federal block grants. This includes 2 significant grants from the Substance Abuse and Mental Health Services Authority, otherwise known as SAMHSA. And this includes the Substance Abuse Block Grant and the Community Mental Health Services Block Grant. And finally, we have grouped responsibilities that fall under California state law. While this is not an exhaustive list, the responsibilities that we will highlight for the purpose of this snapshot are those responsibilities under the Mental Health Services Act, the LPS Act that includes involuntary treatment responsibilities, and the Bronson-McCorquodale Act, which includes community residential and state hospital treatment. And then finally, county safety net services to the extent resources are available. Next slide. Great. So this slide attempts to illustrate the governing authorities as they relate to county behavioral health responsibilities under the Medicaid or Medi-Cal program. As noted on the previous slide, this includes both Medi-Cal specialty mental health services and Medi-Cal substance use disorder services. This includes responsibilities that fall under the federal, state, and local government. The federal government, in this case being the Centers for Medicare and Medicaid Services, set standards for the Medicaid program. So in this case, again, the Medi-Cal program here in California, and provides regulatory oversight, which includes requirements related to quality assessment, beneficiary access, et cetera. The federal government also approves requests for waivers and state plan amendments, which allow states to tailor their programs to better meet the unique needs of their own beneficiaries, test new approaches, et cetera. And then finally, and very importantly, the federal government provides federal financial participation to match eligible state and local expenditures. The state government, in this case being the State Department of Healthcare Services, provides oversight and monitoring of the Medi-Cal program in California. And then for these behavioral health programs, specialty mental health services, and Drug Medi-Cal, which offers the substance use disorder services, the state contracts with counties to administer the programs, and then the state processes the county claims for federal financial participation and the required non-federal share of funds. And finally, the county plays a fairly unique, compared to other states, and very big and critical role in this program by contracting with the state to administer the specialty mental health services and the Drug Medi-Cal programs through a managed care structure for eligible beneficiaries. We'll talk more about that on a subsequent slide. The county in turn contracts with providers to deliver services or delivers those services directly, and very importantly, covers the required non-federal share of Medi-Cal costs with dedicated tax revenues and other eligible funds. And we'll talk more about this piece later on in the presentation. Next slide. Great. So while the focus of this presentation is on the county behavioral health responsibilities, we thought it was also important to note the broader behavioral health benefit available to individuals and families who rely on Medi-Cal for coverage. As we've outlined on the slide, there are really three primary systems of care charged with meeting the behavioral health needs of Medi-Cal beneficiaries. The first being the responsibility of the Medi-Cal managed care plans. So in Santa Clara County being Anthem Blue Cross and Santa Clara Family Health Plan for covering what is considered non-specialty mental health services. So examples of these covered services include psychotherapy, psychiatric consultation, and they are covered for individuals with mild to moderate distress or impairment due to the mental health condition. The second primary system includes the responsibilities of the county in your role as the county mental health plan. So as discussed in the previous slide, this includes the responsibility for specialty mental health services, which includes psychiatric inpatient hospital services, rehabilitative services, and targeted case management for beneficiaries meeting established criteria. So this criteria in part is looking at the level of impairment due to the mental health condition. And finally, the third primary system includes the responsibilities of the county in your role as the administrator of the Drug Medi-Cal program. And this program includes assuring access and providing access to a full continuum of substance use disorder prevention and treatment services. Next slide. Great. So as discussed on a previous slide, the federal government plays a key role in approving waivers and state plan amendments to allow states and counties and plans who contract with states to deliver Medicaid or Medi-Cal benefits under alternative structures. And when I say alternative to the fee-for-service structure that's outlined in the Social Security Act for the Medicaid program. So California has, for many years, taken advantage of these waiver opportunities to deliver specialty mental health services and more recently substance use disorder services through a managed care structure. California has also received approval from CMS, the Centers for Medicare and Medicaid Services, to offer and receive federal financial participation for services not otherwise coverable. And this includes the residential substance use disorder treatment services that are delivered in facilities of any size. And then finally, with these waivers comes a great responsibility for the federal government to assure that there will be an adequate network of providers to assure timely access to covered services and to make sure that beneficiary protections are in place. If a county is unable to fulfill this responsibility, the state must ensure that this responsibility is fulfilled and may sequester county funds to do so. So in sum, these programs really exist as long as CMS, the federal government, is willing to approve these waivers. Next slide. So our federal SAMHSA grants, two key grants here, Substance Abuse Block Grant and the Community Mental Health Services Block Grant. I think the key takeaway on these ones is these grants are really intended to fund services and programs for mental health services and substance use disorder services that are outside of the scope of the Medi-Cal program. Next slide. All right, so to our third bucket now, which is county responsibilities under state law. So the Mental Health Services Act, imagine everyone is very familiar with Prop 63, which was a voter initiative passed in California in 2004. This created a 1% surtax on personal income over 1 million to provide additional revenue for community-based mental health services. So these revenues are distributed to counties on a monthly basis. As you can imagine, given the source, the funding can be unpredictable and fluctuate significantly from year to year. And then the state law as a voter initiative and has been updated over time through the legislative process does provide a structure for how counties shall spend these funds. That said, local boards are responsible for approving those county-specific program and expenditure plans every 3 years, and then the updates that come every year. And then finally, involuntary treatment responsibilities, community residential and state hospital treatment responsibilities. This includes the LPS Act related to involuntary detention, evaluation, and treatment. And I think to underscore the county's role here in designating both facilities and professionals to carry out these responsibilities. And then under the Bronson-McCorquodale Act, there are community mental health services, underscoring the community residential treatment that's provided in institutions for mental disease, and state hospital services for civil commitments that are the responsibility of the county. Next slide. So the last 2 slides here are going to touch on the funding pieces. So state county realignment, 1991 mental health realignment, transferred responsibility for community mental health services from the state to the counties. This includes responsibilities for safety net, community-based services to the extent resources are available, state hospital services for civil commitments, and services provided in institutions for mental disease. So these are those community residential services provided in institutions for mental disease where federal financial participation is not available. 91 realignment is, it's a dedicated portion of the revenue. It's state sales tax, and there are some vehicle licensing fees. 2011 public safety realignment. This transferred responsibility for additional behavioral health responsibilities, most notably the responsibilities under the Medi-Cal program for both specialty mental health services and drug Medi-Cal services. And this dedicated funds from state sales tax. Next slide. And finally, and then we'll end with sort of a looking forward at CalAIM slide. This is a pie chart here to give a sense of the various funding sources that are supporting the county behavioral health system. So notably, the largest funding source is federal financial participation. And noting that in order to draw down that federal financial participation, we have to match it. And so looking at 2011 realignment as your primary source of match in the red, and then Mental Health Services Act and 91 realignment, may also provide some of the non-federal share of costs for the Medi-Cal program. Also, Mental Health Services Act funds many things outside of the Medi-Cal program. Like we talked about, there are requirements in state law for how those funds must be used. And then 91 realignment is a key source of funding for many of those services that are not eligible for federal financial participation, like state hospital treatment and community residential in institutions for mental disease. And just one other sort of thing to say about this chart too is thinking about these funding sources. We talked about Mental Health Services Act can be somewhat volatile. It fluctuates year to year. It really depends on how millionaires and their taxes went. 2011 realignment and 91 being state sales tax driven can also certainly fluctuate and can also be counter-cyclical to need. So the more Medi-Cal beneficiaries you have doesn't necessarily align year to year with where sales tax is going to be. In fact, it may be counter-cyclical. Next slide. All right, last slide, and then we'll pause for questions. Looking ahead, California Advancing and Innovating Medi-Cal, CalAIM, is a multi-year initiative led by the Department of Healthcare Services. It has kicked off. Many of the behavioral health initiatives have kicked off in January of this year and will be phased in over this next waiver period of 5 years. This includes several initiatives that are focused specifically on the behavioral health delivery system. Importantly, behavioral health payment reform, updating criteria for access to specialty mental health services. The drug Medi-Cal waiver program that I mentioned was reauthorized under an 1115 waiver, and a few other programs related to screening and transition tools, documentation redesign, and then administrative integration is in the future to come under the next waiver, but there will be work done in the next few years to look at how to integrate the functions of specialty mental health services and Medi-Cal substance use services under one managed care plan versus 2 plan structures as it is today. So with that, I will pause, and we are happy to take questions at this time.
Thank you, Molly. I appreciate that. Vice President Ellenberg.
Thank you so much, Molly. That was really a great presentation. I know it obviously it focused on the public system, but I just wanted to ask a quick question about the private system as well, so we can have the full picture. The ledge file under the summary of mental health financing references the requirement of private and commercial plans to provide parity for their patients. But as we know, there's minimal enforcement. I'm wondering if you can explain who specifically has the power to enforce the requirements, what are the mechanisms are available, and can the county do anything to enforce that?
Supervisor Ellenberg, this is Don King, and I'm going to ask Molly to help me. So the authority to enforce the requirements related to parity, there is a federal requirement that parity be enforced, but the actual enforcement at the state level depends on the state entity that oversees the managed care plans. And from an enforcement perspective, largely complaint driven. But as you know, Kaiser in Northern California did experience and went through a complaint process related to access and having an adequate network. So there is some enforcement that we see here in California. And Molly, anything that you'd like to add?
Yeah, it would. It does depend on the type of plan, but it would be the Department of Managed Care or the Department of Insurance at the state level that should play a role in parity enforcement. And this is, this has definitely been a hotter topic, if you will, over the last few years. And so I do believe there's been some, advisory groups and work done, particularly at the Department of Managed Health Care, to look at parity enforcement. But it is a really good point. It is, if that is not happening, then you do put additional pressure on the public system.
Right, and if the county can't directly enforce it, I'm thinking that it might well be in our interest to at least provide extensive education and support for folks that are using the private system in our county to make sure they know their rights and what they can do exactly for the reason that you described, Molly, so they're not falling back to the county system. Thank you both for that.
Thank you. Supervisor Chavez.
Thank you. And just as a follow-up, could you just spend a minute talking about where you see the opportunities relative to CalAIM based on the current structure, and then in alignment with what Supervisor Ellenberg asked, how, if at all, do the changes in CalAIM potentially impact how we provide these services, mental health services?
Yeah, I'm going to start this, Don Kingdon, Supervisor Chavez, I'm going to start, but then ask also Molly, who has quite a bit of on-the-ground expertise with this, to fill in. I think one of the significant changes, there will be some significant changes related to financial structure that will impact the counties. One of the things that will be very important, as you saw that big part of the pie, the federal financial participation is really driven by claims, the efficiency of claims, both for directly delivered county services, but also for subcontracted services. And going forward, the new financial structure under CalAIM will even underscore that more, that the county and its subcontracted network will have to be very efficient in being able to generate and have those claims adjudicated through the state system. I'm going to defer to Molly on some of the other very important programmatic and other changes.
The one other initiative I would underscore, and I think this is actually a thread throughout a few of the initiatives on the behavioral health side within CalAIM, is a desire to see the county behavioral health system and the Medi-Cal managed care system work more collaboratively. And so there are, as an example, there's an initiative to develop standard statewide screening and transition of care tools that both the county mental health plan and the Medi-Cal managed care plan would use the same tool in order to have both referral pathways that look the same into both systems, and then also have an opportunity to make sure that folks are, they come into the system, somebody, sort of make sure that they get to the right place, so we don't have folks ping-ponging back and forth. And so I think that's a thread you'll see through a number of initiatives. It's really a desire to make sure that the systems are working in very close collaboration, so that the fact that we do have this very complex system, as we've just very quickly described here, is hopefully less apparent to the beneficiary in terms of its your ability to access care should be seamless regardless of the complexity of the system. So just, I think that's a big theme in the CalAIM initiatives for behavioral health.
And I would just to call attention to the oversight structure that Molly went through. It's very important, I think, that the counties understand that the federal government is waiving a number of rights for beneficiaries, trusting that the state will implement the program consistent with the beneficiaries, the enrolled beneficiaries' needs. And then that oversight, as you know, then comes down to the county through the state. So I think often, and as also Molly said, if the county is unable to perform, the state does have the authority, if the federal government agrees the county is not complying, to bring the program back in and subcontract elsewhere. So that structure is very critical from the federal government's perspective.
Then what I hear you saying about efficiency in billing means learning how to do more and new paperwork better. Is that it?
No, actually, the state's done a pretty good job of reducing the amount of paperwork focus and instead move to a uniform coding structure through CPT and HCPCS coding. So the state is modernizing, bringing the coding structure into compliance at the federal level. And I actually think their goal is to give the counties the tools necessary to be as efficient as possible in submitting those federal claims. So we do see some real positive movement at the state level to get away from paper and use the coding structure more efficiently.
Wonderful. Thank you.
Thank you. I think with that, we can continue on. Molly and Don. I don't have a page number on this, but it's a pie chart entitled 2021 Behavioral Health Services. Sherry, Sherry, is that you?
That's me, Supervisor. Thank you, Don and Molly. We really appreciate your being here with us this evening.
Thank you.
Thank you. So I'm going to go ahead and take us through the next set of slides. Following this, we'll pause at the end of the presentation for additional questions. We wanted to first start off with just showing the number of clients that we currently serve in our behavioral health services system. You'll see in 2021, we served 31,449 clients. This includes 9,000 children, 5,500 youth and young adults, and 17,000 adults and older adults. You'll see the breakdown on the far right, with 94% of our clients generally served through the outpatient system of care, with a smaller percentage focused on short-term acute facility services, or about 4%, or 1,300 clients served in short-term acute facilities, 1% being served in our Barbara Aarons Pavilion, and 1%, or 360 clients served in our long-term locked facilities. Next slide. This slide focuses on our system of care principles and objectives. Both Dawn and Molly highlighted some of our responsibilities as a behavioral health plan, but we wanted to just share some of the guiding principles and objectives that we're focused on here. The right to behavioral health services and well-being across the lifespan, achieving recovery from mental illness can be done. The focus on equitable access to quality care and cultural and linguistically competent services. In our county, we've really done a lot of work around prioritizing trauma-informed systems and cross-systems integration. Our objectives in our systems are to interrupt the cycle of emergency services, hospitalization, and incarceration, strengthening the community-based system for those most in need, prioritizing access to appropriate levels of care and aligning capacity to demand, increasing efficiencies, and that will become even more important as we move forward with CalAIM, and finally, maximizing residential and co-occurring capacity in our system. Next slide. We wanted to provide some information related to how individuals access our county behavioral health system. And the first pathway you'll see at the very top is through our crisis services. So an individual may experience a mental health crisis necessitating assistance. In Santa Clara County, we have a mobile crisis response team program, or MCRT, that serves adults. Our psychiatric emergency response team, or PERT, which includes a clinician paired with law enforcement, and mobile response and stabilization service for youth, which is provided by Uplift Family Services. This summer, we will be launching the TRUST program. TRUST stands for Trusted Response Urgent Support Team. And through the support of the Board of Supervisors, this program was designed as a community support as an alternative to law enforcement response. The program intends to proactively help individuals in crisis for any behavioral health related situation where an individual needs assistance in resolving conflicts or stressful situations. This program team will consist of a first aid responder, crisis intervention worker, and peer outreach specialists to help individuals experiencing an increased level of stress and anxiety by conducting assessments for medical and/or behavioral health needs to minimize and prevent further escalation of crisis and provide the individual the support they need when they need it. Depending on the outcomes of these responses, an individual may be referred or offered immediate support and referral for services, and if necessary, may be transported to emergency psychiatric services, or EPS, for further evaluation. Individuals in crisis may also call our suicide and crisis line or may access support via our crisis text line. The second pathway is focused on how individuals access our outpatient services. These individuals can call our behavioral health call center for mental health services and Gateway for access to substance use treatment services. The caller will be provided a brief screening, and depending on their needs and level of care, are referred to a contracted provider or county program. Later in the presentation, we will be sharing plans for consolidating and streamlining the phone numbers for access to services. This has come up during COVID-19 and during the pandemic, where there was a recognition that accessing our services through multiple numbers can sometimes prove to be challenging for the community. Before I move on to justice services, I wanted to highlight again with respect to the crisis service pathway that there is also a walk-in opportunity. Our behavioral health urgent care offers screening, assessment, crisis intervention, referral, and short-term treatment to provide immediate relief to people in distress. And the program is really designed to help the patient avoid involuntary hospitalization, psychiatric emergency room visits, and incarceration. Finally, the last pathway is around justice services. And in this instance, a referral can be made by a probation officer, the court, or reentry. And the referral is processed through a centralized authorization unit, behavioral health resource center, and they are connected then to one of our behavioral health providers in our network. Next slide. So as we shared in the prior slide, for those experiencing a mental health crisis, there may be need for further evaluation. As Dr. Smith described, under California law, only designated professional personnel can place a person on a 72-hour hold, often referred to as a 5150. Law enforcement officers, mobile crisis team clinicians, or other mental health professionals authorized by the county that have been issued a 5150 card after training can place someone on a hold. One of the three conditions must be present in order to place an individual on a 72-hour hold. The designated personnel believes there is probable cause that because of a mental disorder, the individual is a danger to themselves, to others, or gravely disabled, which refers to the inability to provide for their basic personal needs for food, clothing, or shelter. In this situation, an individual may be taken to emergency psychiatric services or EPS, where they are evaluated for psychiatric medical conditions, and a determination is made for ongoing stabilization. If it's determined that the individual requires inpatient hospitalization, our 24-hour care team assists with identifying a bed in a contracted acute inpatient hospital or Barbara Aaron's pavilion, or if the individual is stabilized, they may be referred back home with services, including reconnection with their existing provider or a referral to a new provider if they have not yet been connected with services. If the individual is unhoused, every effort is made to assist with securing shelter, including a referral to a shelter or motel and a referral to the in-home outreach team. For those entering a hospital, they will be held until stabilized and may be referred back home to the community and or to a crisis residential or residential care facility. So in the center of the diagram, you see the two turquoise boxes, and that refers to individuals who may be referred to crisis residential or residential care facilities. For those that do not stabilize within the initial civil commitment timeframe, they may be referred to the public guardian's office. Upon referral to the public guardian's office, a determination is made based upon an independent medical provider or physician assessment to determine if longer-term services are needed. This process then informs whether or not to request the court to start a conservatorship, and this process may lead to placement in an IMD, and these two orange boxes here refer to placements that are part of a legal process. So an individual may be referred and placed in an IMD or an Institute for Mental Disease bed or the state hospital, and that refers to these two boxes there. On the far right bottom part of the diagram, a client may also be transferred from emergency psychiatric services or EPS to the Mission Street Recovery Station in situations where it is determined that the mental health condition is substance induced. And at times we have individuals that are taken to EPS where that determination is made, and then the individual is referred to the recovery station. And again, just highlighting for those that are unhoused, a connection to Valley Homeless Healthcare Program may be necessary in order to access primary care services, legal and social support services, dental, mental health, and substance use services. So that was a lot of information. I'm going to move on to the next slide. This slide details the process for an adult client to access outpatient services. In this situation, the call center will receive a referral from the outpatient team or inpatient hospital and makes a referral to one of our intensive programs, including assertive community treatment, intensive full service partnership, or full service partnership programs. The board has been very supportive in adding additional services when needed to ensure that we have adequate intensive supports for our beneficiary and community. For IMD referrals, the 24-hour care team liaison coordinates with the contract monitor and notifies the call center. From there, the provider notifies emergency psychiatric services, the hospital or client of their scheduled appointment on the same day of the referral. In situations where the client does not attend the appointment, the provider will engage in outreach for up to 60 days. And if engagement is still unsuccessful, the client may be referred to our in-home outreach team for additional outreach and engagement. If engagement is unsuccessful, the referral may be closed. And we wanted to highlight, I think what's important here is through the support of the Board of Supervisors last summer, we opted in to providing assisted outpatient treatment, AOT, for those with the most serious mental health challenges who continue to struggle with engagement in services. And AOT can actually serve as a bridge to connect individuals who are most in need of services to outpatient care. Next slide. This slide describes different types of adult and older adult sample patient profiles. It's important to note these are not real clients, but we wanted to share a range of examples of the type of clients that may present in the behavioral health system. You will note that there are a range of diagnoses, and even two clients with the same diagnosis may present with different risk factors or complicating health factors that may contribute to a higher level of need, therefore resulting in a more intensive level of care and a different mix of services. So all this to say that no two beneficiaries or clients are alike. There are always unique sets of circumstances that impact their mental health conditions. Next slide. We wanted to share just an overview of our adult and older adult system of care budget. I think in conversations that we have with the community, there's all sorts of assumptions about how much we do truly invest in behavioral health services. And for the adult and older adult system of care budget, you can see the total FY22 budget was $287.2 million. You will note that over half of the budget is spent on outpatient services, along with 30% focused on intensive and residential care, and a smaller percentage spent on prevention and early intervention, crisis services, and supportive housing. But this is a very significant amount of funding that is made available for our adult and older adult system of care. Next slide, please. We thought it would be really important to walk everyone through levels of care. And this is really related to psychiatric beds. And psychiatric beds are essential infrastructure for meeting the needs of individuals with mental health conditions. However, not all beds are alike. They represent infrastructure within different types of facilities, ranging from hospitals to community residential facilities. The facilities serve clients with different needs, some who have high acuity, short-term needs, and others who have longer-term needs and may return multiple times for care. These levels may be categorized as acute, subacute, and residential. And when we refer to acute levels of care, this refers to acute psychiatric hospitals, psychiatric health facilities, acute beds at the state hospital, and acute care hospitals with psychiatric wards. And who accesses this level of care are conserved or severely mentally ill clients who require the highest level of care to stabilize them, who may be in danger to themselves or others and may be placed on a hold, as I've described earlier. Subacute refers to mental health rehabilitation centers, skilled nursing facilities, or institutes for mental disease, or IMDs. And who accesses subacute care are those who have gone through acute care and have ongoing needs. So as I've stated, at the acute care level, most accessing subacute would have gone through an acute care level of care. And again, this includes conserved or severely mentally ill clients stabilized enough to step down from inpatient facilities, but with specialized needs that preclude them from living independently in the community. These individuals may require one-to-one nursing care and longer lengths of stay. And finally, residential care includes adult residential treatment, enhanced board and cares, and who utilizes this level of care are clients that may be referred from crisis residential or the community. And this represents the least restrictive setting following acute and subacute care. This includes clients diagnosed with severe mental illness, but who have less severe specialized needs, who can obtain outpatient treatment to live in the community.
Sherry, if I can interrupt you for just a minute. That's page 10 of your slide. Excuse me, that's page 9 of your slide presentation so far, and we've gone 20 minutes. We have 100 pages left to go, and you and I should have talked about this earlier, and I apologize. That's my responsibility. But at a couple of minutes a page, we still have more than 3 hours of reading to go. So I need to find a way, perhaps when you can summarize the pages a little better, and
Okay.
spend a little less time on each one. There's just,
Sure.
yeah.
I do want to spend a bit of time on these 2 slides, and I think there's been a lot of interest in understanding specifically the types of beds, what are needed in our community. And so I'm happy to, be brief on the other slides, but I am going to take a little bit of latitude, at least on the next slide as well, to talk a little bit more about this. We'll move to the next slide, and this is related to bed capacity and needs. This chart describes the bed type and plan to increase beds. We appreciate the support of the board as you have recently approved the addition of 29 IMD beds this fiscal year. As stated in the slide, we are implementing several strategies for increasing beds, including the purchase renovation for placements utilizing MHSA funding, available grants, increasing rates for RCF beds, developing 650 South Bascom for additional adult residential treatment beds, and working on an application to the state for additional funding for residential care facility beds. In a recent study conducted by the RAND Corporation related to adult psychiatric bed capacity, they estimate in the San Francisco Bay Area, and that includes the counties of Alameda, Contra Costa, Marin, San Francisco, San Mateo, Santa Clara, and Solano, that we are short approximately 1,500 beds across all categories, and project a 2.1% increase in beds will be needed by 2026. RAND also emphasized that in order to solve for the bed shortage, we cannot simply examine current bed occupancy rates at each level of care and build more beds where occupancy rates are the highest, but rather they emphasize the need to understand what drives occupancy rates at each level of care, including unsuccessful transfers and hard to place populations. Next slide. These are a listing of our adult and older adult initiatives, many of which you are aware. Again, looking to increase residential beds, increasing our community response and mobile crisis availability, and increase approach in fentanyl prevention and outreach. I've described AOT, our independent living empowerment project, and continuing to increase availability of service slots. Next slide. I'm not going to go through this slide in depth, but again, just similar to the adult profiles, this shows the range of need amongst samples of youth served in our system. Again, these are not real clients, but again, we wanted to share just some of the types of client profiles that we serve. And again, on the youth side, it's really important to note that there's a range of diagnoses for children, youth, and adolescents. And this may be further impacted by development, substance use, school, peers, system involvement, including child welfare and juvenile justice involvement, and familial challenges that contribute to the varying levels of need and different mix of services. Next slide. This breaks down the children, youth, and family system of care budget, $167.7 million, with about 3/4 of the budget focused on outpatient services and a smaller percentage focused on prevention, early intervention, crisis, and residential. Next slide. The board has wisely invested in dedicated funding for schooling services over the years, as well as is really looking to expand school-based behavioral health services, as well as prevention efforts, including substance use and suicide prevention and other innovation approaches, including programs like ALCOVE. This map reflects the saturation of risk factors in our community, with the darker shaded areas reflecting greater needs. And the placement of these services in the areas of greater needs are really intended to both prevent and treat mental health and substance use amongst children, youth, and transition age youth. Next slide. So we wanted to, on this slide, point to some solutions and strategies that we're working on. Clearly, the addition of beds is going to help us ensure that we have adequate capacity to be able to serve. We're continuing to look at expanding behavioral health outpatient services. We'll go into, in the latter part of the presentation, workforce strategies, housing strategies, our crisis capacity expansion, the behavioral health navigator program, which we're working on. We've just launched AOT this month, and we're continuing to work with our contract providers around contract flexibilities to facilitate continuity of care, as well as our county contract provider NetSmart implementation. Next slide. And finally, we wanted to highlight some of our strategic objectives. Again, ensuring that our beneficiaries are provided timely access to high quality services, being proactive in addressing the ongoing needs of COVID-19 emerging from the pandemic, ensuring that we have appropriate levels of quality care. As I've stated, expanding temporary residential and permanent supportive housing, looking to develop innovative solutions, which you'll hear about related to the professional workforce shortage, strengthening infrastructure, and developing and deploying integrated clinical teams. So with that, I will go ahead and turn it over to Keely, our Deputy County Executive, who will present on permanent supportive housing strategies.
Thank you, Sherry. Vice President Ellenberg, you have your hand raised. Go ahead.
I do. Before we go on to housing, I wanted to just ask a couple of questions and make some notes here. Sherry, thank you. Thank you so much, really, for just starting to walk us through this. The numbers, the page that you gave toward the beginning, the number of people that were served in a year, does that include people served through custody health?
Includes all of the clients that were served in our behavioral health services for 2021.
So when you're describing adults and older adults, that would include people that are involved with the justice system. Sorry, I'm slipping out of my chair.
Yeah,
or entirely unconnected with the criminal legal system.
Yes, it includes everyone that we would have served or provided a behavioral health service to in 2021, and that would include individuals involved in the justice system.
Okay, thanks. And also just noting some statistics, Dr. Smith at the beginning noted that 3 to 4% of any given population is estimated to have serious mental illnesses. That would be about 80,000 people in Santa Clara County. If we're serving about 30,000 a year, do you have a sense of whether we have an unmet need that's more than twice what we are currently serving?
I would say that we are continuing to look at opportunities for increasing our penetration rate of Medi-Cal beneficiaries who may need a service. With respect to the general population and those that are, insured commercially, I wouldn't be able to comment on that. But with respect to our Medi-Cal beneficiaries, we are continuing to evaluate how much service is provided.
I think that's actually a really good point that I wasn't thinking through, that it wouldn't be our responsibility necessarily for all of them, and we shouldn't presume that 3 to 4% are all Medi-Cal beneficiaries. So I appreciate that. And as we go through the numbers with the beds, what I'd like us to get to is, and this might be what's coming in April, is something that really looks strategically at where our unmet needs are. Where are the waiting lists and the bottlenecks? Where specifically do we have greater need? And is that need addressed by building facilities, by contracting more slots with other facilities? It's really not very different from the childcare three-legged stool. I think we need to be looking at facilities and workforce and the right slots for the right needs. So is that where you anticipate all of this data moving toward in the April report?
Yes, we will be looking to further explore that and coming back with specific work plans as per the referral that you put forward that would articulate around the strategic objectives, a work plan behind that. And part of that would be including looking at unmet needs.
Thanks so much. That's all for right now.
Supervisor Lee.
Yeah, thank you, President Wasserman. Thanks for the really great overview, Sherry here. I was asking basically a similar question that Supervisor Ellenberg has mentioned regarding the issue of, the unmet needs of the number of beds. If you look at page 27, all the different number of beds is explained on page 32, that practically every single area, IMD, RCF, adult residential treatment, crisis residential, everything is basically not sufficient to meet the need right now. So basically, you would say that every one of these is a bottleneck at this point until we could get more beds established in all these categories, right?
Yes, I think as Keely will go through in his next section, it's really articulating some of the challenges and complications that lead to sometimes the difficulty in precisely identifying the specific number of beds at each level, because there are so many confounding factors that continue to impact a person's care. And I think because not every individual goes through the system in a linear way, they may be going back and forth between different levels. And so that really does, in fact, influence, how we arrive at addressing the current need.
Right. And on page 28, on the chart for the outpatient care, you mentioned the AOT that we just started, but I'll just ask to maybe get that that box added to the chart, because I think that chart probably is made prior to AOT being established, correct?
Yes, we can definitely add AOT to the chart.
Yeah, now, on the pie chart, looking at the adult older system of care budget on page 30, it shows that clearly the majority, close to 57% outpatient, and that 30% is residential intensive care, which certainly makes sense. The one thing that did not seem to make sense to me is the budget on the prevention and early intervention, where I'm looking at here, it says only 2% investment is on that. Compare that to the children, youth and family system, which is 15% on prevention and early intervention. Certainly 15% I still think is pretty low, but I'm very surprised why that is so low on the adult side.
Yeah, so our Mental Health Services Act planning process, which includes a component of prevention and early intervention, is really guided and advised by our stakeholders. And so over the years, our stakeholders really help inform, the way in which some of these services and opportunities should come forward. And I think, in each of our planning processes, we're continuing to ask about whether our existing priorities are still ones that we should continue to fund in the way we are. And so it may be an opportunity to look at whether some of those prevention and early intervention opportunities can be increased for adults.
And as we all know, by spending more money on the early intervention and prevention, very likely it will save us money down the road for the more expensive and intensive treatment when people get more sick, right? So I think that's something I would be very, very concerned to make sure that we are putting more investment in that. So yeah, we're really looking forward to look at that.
And just, sorry to add to your comment, Supervisor Lee, with respect to children and youth, there is a really significant opportunity to be able to intervene early as youth are developing. And so historically in our county, we have been very thoughtful about ensuring that we properly resource our prevention and early intervention efforts. And those are significant partnerships that we've had for many years with entities like First Five, education, to ensure that we're really thinking preventatively and giving our children the best opportunity and start in our county.
Great. So basically, I just want to say we'll see if we could ask to look further upstream to focus greater proportion of our investments in prevention and also in children as well in terms of experiencing the crisis. So I think that would be a good money spent on that. All right, that's all I have for the time being. Thank you.
Thank you, Supervisor Chavez.
Thank you. And Sherry, thank you for all the information. I'm going to save some of the bigger comments for the end, but I was thinking a little bit as you were describing the services that I think your point is right, that we have to remember that these aren't linear. And often when we think about the continuum, we literally think about it on a horizon. And it really is much more of a chutes and ladders sort of construction, meaning that, you know, people move up and down based on all kinds of different external and maybe familial and all kinds of factors. And so one thing I would just say that I think is going to be important is that we figure out a way to properly represent the experience people have. And the other thing I would just say with chutes and ladders, it's a little different than the game, is that the way chutes and ladders works is that you can move up or down and you land in a square. And I think the fact is this, I'm showing my age, right, Mike, that you and I both know what that game is. But I think we have to also recognize that the chutes and the ladders actually come off the board, right? That sometimes people really do fall through the cracks or they move into a different system. And the reason I mention that is that I think that one of the questions that I was hoping to get wrestled to the ground tonight is when somebody is seriously mentally ill, and they end up in the criminal justice system or they end up in our system, what happens to them? And how do we manage those relationships? And we had a contract, or we had made a request to expand all of our nonprofit partner contracts to do so that they could demonstrate the practice of engagement. And what I'd asked for was, okay, if we're expanding all these contracts, how many people are we engaging with, and how many of them are we able to move to a service? And one thing I just want to make sure that we figure out a way to have that conversation, at least a little bit of it tonight, so it's framed up, Sherry, so that we can talk a little bit about the next steps. Now, I see some of those next steps, like being able to expand the IMD beds, which I really appreciate that we're going to have to both invest in the tail end of the services and in the prevention end, because really, in some respects, I feel like we haven't done either of those ends as heavy investment as we've had on this middle part. But anyway, that may not be accurate, but that's kind of how I'm thinking about it. But what I don't see here is a reference to detox and the significant overlap of that fact that we have so many more people that are engaging with meth and other things. I know you're going to cover some of that, but I just wanted to identify detox, and I wanted to identify that from our discussions with the public guardian, I think we don't have enough public guardians doing this work, and there aren't enough placements. So from speaking with the public guardians, and I think it was a meeting, Sherry, you and I and Supervisor Ellenberg were at, public guardians said, yes, we would do more of this. We don't have placements. So when we're dealing with seriously mentally ill folks, how do we help them? And I think that the question I would like to get answered is for the multiple people I saw on the streets of San Jose today, because that's where I was, how do they get engaged in the system? How do we support them through the system? Because they can't use warm handoffs the way everybody else does. And so anyway, that's really a question I would like to get, as you're doing further explanations, help us better understand that. And even on the prevention side, I think we do have some evidence-based opportunities, I think both with Healthier Kids, and one of the things I'm really excited about is our own diagnostic center and the ability to expand that as an opportunity for early intervention and prevention. So colleagues, those are just some broad thoughts. I'm really looking forward to the rest of the presentation. Thank you.
Thank you, Supervisor.
Thank you. Thank you, Sherry. Move on to Key. Mr. Lee.
Thank you, Supervisors. Key Lee here, Deputy County Executive. I'll just make a few brief comments on the housing strategies. As part of this workshop, what we wanted to do was to introduce a framework for increasing the housing stability of children and their families and adults who are participating or who would be eligible for the special mental health system. That framework is attached as attachment 6. And I'll just try to sort of summarize and underscore a few of Sherry's comments. We think that the sort of underpinnings of this housing framework are really two strategies. One is a housing stabilization program or homelessness prevention, principally because the overwhelming majority, over 90% of families and households served by the special mental health system are, despite challenges, stably housed. Preventing homelessness as crises arise is, I think, a critical strategy in sort of maintaining our system. The second is that for some individuals with severe needs and a multitude of conditions, they will require some form of ongoing financial assistance or deeply subsidized housing, along with ongoing supportive services. You all know this as permanent supportive housing. But for everyone's edification, especially the public, we mean permanent supportive housing in apartments that we can rent, apartments that we can build, in residential care facilities, in shared housing, all types of environments. And these two programs combined, I think, can over time really improve and reduce homelessness in the special mental health system. And the lack of these housing opportunities, I think, really distorts the level of need at the acute level, subacute levels, and residential treatment levels. As Sherry indicated and others have indicated, many individuals do need temporary treatment in other settings based on their conditions. The vast majority can return home. The lack of a home or the loss of a home when they are in those settings can delay access to appropriate levels of care or further distort the number and types of beds that we have. So we hope to return to the board in April and to provide a little bit more detail about how we will proceed and what opportunities exist. And along the way, of course, we will be implementing a few system changes that give us a better understanding of the housing needs. Thank you.
Thank you.
Great. Thank you, Key.
Dr. Sherry.
Yes, I'm going to go ahead and introduce Jan Morale, our program manager with our Behavioral Health Services Department, who will take us through the next part of our presentation.
Thank you.
Sure.
Welcome, John.
Thanks, Sherry. Good evening, Board of Supervisors. I'm Jan Morale, Behavioral Health Services Division Manager supporting the Department Systems Initiatives and Planning. In addition to the various initiatives that have been covered so far this evening, I'll be covering 4 other ones we are working on. One is around the consolidation of the county's behavioral health phone numbers. Second, how we are working towards developing integrated clinical teams. Third, ensuring that the services provided by peer support specialists are a prominent aspect of the integrated treatment model. And fourth, addressing workforce shortage, as Sherry mentioned earlier. So for the first area, to provide some context, from December 2020 to January of 2021, our department held various planning input sessions in partnership with community-based organization during the development of the county's new community mobile response program, now called Trust. Now, during those input sessions, we heard directly from clients and consumers, family members of clients and consumers, and members of the public who shared comments about access to the service, specifically around the phone number. Some shared that a 3-digit phone number would be easier to remember than a 10-digit number, especially if one is in crisis. Additional feedback from the 12 input session also included that it would be helpful to have a centralized point of contact, have services be available 24/7, and have it be available in a fast and responsive way. So let's fast forward to this fiscal year. Next slide. So this fiscal year, our department has been working on consolidating the county's behavioral health services phone numbers based on the feedback we received at those public session, and really making it easy for the public to access services. We are doing this in 2 tracks. One is implementing a plan to use the 988 phone number for members of the public to access behavioral health crisis services, and a second track to implement a specific number for a non-crisis behavioral health phone line, specifically for our county's Medi-Cal beneficiaries of mental health and substance use services and other non-urgent related services. We hope that by working towards this consolidation of phone numbers, we aim to improve the public's access to behavioral health crisis and non-crisis services. Next slide. The second area I would like to go over is the department's commitment to developing and implementing integrated clinical teams. This fiscal year, we will be implementing a co-occurring training certification program. And this slide reflects the department's co-occurring training plan for staff to become informed, capable, and enhanced in their levels of practice when working with clients with both mental health and substance use issues, with the first level of training at the informed level going live next month. Next slide. Regarding this third area, as we move forward with our work, we want to ensure that we have peer support specialists as an essential aspect of the integrated treatment model. And this slide reflects the training plan we have for our peer support workers, staff, to help them in their work as part of our integrated support teams. And you can see here the training plans we have planned for this fiscal year through next fiscal year, as well as ongoing activities. And then lastly, next slide. We have developed strategies to address the professional workforce shortages that we, the county, as well as our community-based partners are encountering. Here you see some of our implementation efforts from short to long term. And one of our short-term strategies, including convening a workforce committees with participation from both department and CBO staff members in developing the program criteria for the county stipend and loan repayment program. We are also looking to expand our partnerships with local universities to build our workforce while also continuing to implement the county's peer and student intern program. Now I turn this over to Elisa Koff-Ginsburg, who will present on the next topic.
Thank you. Good evening. I'm Elisa Koff-Ginsburg with the Behavioral Health Contractors Association, or BHCA. Thank you to board members for calling for this workshop and to the Behavioral Health Department for including the experience of community-based providers in the presentation. For several years, all behavioral health providers have pointed to workforce as their greatest challenge. Then I started hearing the word crisis used on a regular basis. Most recently, one provider noted that they've been in the field for 40 years and have never seen anything like this before. We can't approach the workforce crisis in terms of individual organizations. What is at risk is the entire behavioral health safety net. The areas where we are taking and can take more action are compensation, recruitment, education training, and pipeline, use of unlicensed staff paraprofessionals, and retention. Next slide. Oops. For everything on this slide, the black lettering is currently implemented and the red is just starting or ideas for the future. As you've had the slides to review, I'm not going to mention all the strategies, but we'll highlight a few. I hope you will ask questions if you would like more detail on those I do not highlight. Also want to point out that you will see overlap, as you would expect, between what you just heard from the department and what I will be sharing. When thinking about compensation, providers recognize they're operating within a regional market-based pay structure. Competitors in hiring are no longer just the county and Kaiser, but include all health insurers, schools, and even high-tech companies. Some providers have taken the risk of raising salaries before a rate increase is finalized, counting on it happening, while others are desperate to be able to do so. I cannot underscore that the county's use of cost reimbursement during the COVID emergency is what has allowed organizations to survive, retain their staff, and continue to offer services. The next critical step is to increase provider rates, and we're grateful the county is working on this. It can't happen soon enough Every day, I hear from my members about staff leaving their organizations. Beyond a current increase, in order for providers to plan and continue to be competitive in the long term, providers need a regular cost of doing business increase. In terms of recruitment, BHCA providers have had to change their approach to hiring. Of note is the use of referral bonuses. For example, many agencies have a $500 bonus to existing staff if someone they refer is hired and stays 6 months. One agency has upped this to $1,000 for clinicians. I do want to emphasize the strategy of no direct targeting of other safety net provider staff. BHCA members recognize that every time a staff leaves an agency, it creates disruption for clients. Recruiting back and forth from each other would only serve to hurt the clients needing the services. BHCA members have an agreement not to directly recruit staff at other agencies. Of course, as agencies post positions, anyone who is looking will apply, and there certainly is movement within the system, but there's no direct recruiting of other agency staff. Providers have had to go as far as to tell recruiters they hire that this is off limits. We have asked the county for the same thing. It's understood that as jobs are publicly posted, CBO employees may seek county employment. But we've asked that the county proactively tell all staff involved in hiring not to send recruitment emails to CBO staff on their work email accounts. And finally, I'd like to highlight the proposed strategy of the county creating a multimedia career ad campaign to entice students to join the field of public behavioral health, be it with the county or community-based providers. Given our county's diverse population, any effort to cultivate a workforce that reflects that diversity will require multiple languages, media, and targets. We feel the county is positioned with the resources to develop this, and of course, we would want to partner. Next slide, please. A big challenge to focusing on building a pipeline is the demands on everyone to focus on providing services. But it is critical that we take the time to do so to protect the ability of the behavioral health services system to meet network adequacy. One effort underway involves behavioral health providers and other nonprofits involved in the REAL Coalition, looking to develop a non-clinical behavioral health training model that would provide opportunity to entry-level staff to progress in behavioral health careers. Currently, a planning grant from the Silicon Valley Community Foundation will allow for exploration of different models, and we've started to uncover a range from organizations working with high schools to community colleges to a Kaiser-funded initiative that is open for anyone to participate and then go to work at any location. All of these are potential partners. In terms of the supply of clinicians and counselors, the size of the behavioral health programs at California public colleges and universities is key. And we would like to partner with the county to push for greater state investment in the field to make sure that there is the workforce to hire. Next slide. One tremendous resource we do have are staff who are unlicensed paraprofessionals and those with lived experience. They are committed to serving this population. Providers strive to utilize licensed staff only for services that are uniquely in their scope of practice, and to make sure that the non-licensed staff, experienced staff, is utilized in all areas within their scope of practice. There are two areas where county action could have a large impact. Our county has imposed requirements that are more stringent than the state requirements for service provider qualifications. At this time of a workforce crisis, which limits our ability to provide services, we urge the county to align with the state requirements in all positions. An example of the impact of this going beyond current ability to provide services can be seen in the case of the RADT. The RADT is the entry-level classification to substance use treatment careers and is the position San Jose City trains for. The state allows this level in outpatient services, but our county does not, sending the students from San Jose City to work and gain experience in private clinics, and then often go on to work at those clinics. We recommend an evaluation of what qualifications are essentials for staff at each program level to ensure we are not limiting the maximization of our available workforce. Next slide, please. This area best exemplifies why I often say that increasing compensation is necessary but not sufficient to solve this crisis. As you can see on the slide, providers are using all sorts of strategies to retain staff. One of the strategies I want to highlight is having an employee loan program. Particularly for low-paid staff, everyday challenges such as car troubles or illness can lead to disruptions that impact ability to work. An employee loan program makes funding available as a loan so an employee can address that current crisis. I also want to highlight that providers are also utilizing data, holding interviews with teams facing greatest attrition to learn what helps them stay, and analysis of exit data when their staff leaves. The list of strategies you see here is extensive, but the most impactful actions are those that can only be taken by the county. One of the top reasons employees cite for leaving public behavioral health is the administrative burden and documentation required of them. The county can make sure they're not adding requirements above those mandated by the state, and we invite their partnership in advocating for the state to review requirements with the impact of work on their workforce in mind. I also want to mention another interesting idea that we could do in partnership, which is the creation of a team of floaters, trained staff that would float between CBO providers and county service locations to cover vacancies and leave. Next slide. BHCA members very much want to partner with the county to develop and implement a comprehensive workforce strategy. As I said at the outset, the stakes are very high. We don't want behavioral health services to become something that is available only to those with money and means, because there are not enough staff to work in what is now a well-funded safety net system. BHCA and the county are not able to take on this Herculean challenge individually. We are confident, however, that collectively we can move toward a successful, comprehensive workforce strategy. Thank you.
Thank you, Elisa. Vice President Ellenberg.
Hey, Elisa, that was really an outstanding report. And I feel like you really threw down a very legitimate gauntlet for us to work really productively together, because it's clear that neither one of us can really fully succeed and serve our purpose without the other. So I really appreciate the direct presentation and the specificity. Could you give an example or two of places that the county standards or expectations exceed those of the state, just so that our team has some awareness of that?
Sure. I mentioned specifically the RADT, which is the entry point and often has the most community-based and diverse staff that are coming into work in the substance use treatment system. I think the reason we're talking about needing to have a review of all of this is there's so many different things, whether it's data collected or assessments done in all different programs, that in and of themselves make a lot of sense from a clinical perspective. but they can have a really detrimental impact on the work of the staff person and the family when they're overwhelming. And at the same time, they add to the administrative burden. And often these are not used in other settings like schools or at Kaiser. And so staff leave. Maybe they're okay with the compensation, but they just don't want to do that. I think the challenge that is really out of the county's control is what is required by the state in terms of documentation and preparing for auditing. And I think that's where our state association, I know, would love to partner both with our county and all the counties to try to get the state to focus on that.
Thanks. I appreciate that response. And I don't know if Dr. Smith or Sherry want to just kind of make a high level statement about whether philosophically we need to adhere to stricter or different standards, or whether the general idea to you of making sure that we're aligned is something that should be part of our practice.
Sherry or Dr. Smith? Sherry.
Sure. I think we're always, of course, looking to ensure that we follow state guidance. There are certain circumstances in which we may consider different local requirements with respect to services or programs. And the example Elisa shares around the substance use interns, interestingly, we held a higher standard, and recently the state has adopted that standard. So I think it truly varies situation by situation, but we do recognize that the professional workforce shortage, and as Elisa described, the many factors that are contributing towards clinicians and other staff electing to take other positions, is important to think about. And I see Dr. Smith has his hand raised.
Dr. Smith.
Yeah, I would just add, sort of as a generality, Sherry and the team have been working closely with the Behavioral Health Alliance, working on contracts, trying to get them right sized, trying to find ways to provide additional support. And I think they've developed over the years a very good working relationship. So, we're very interested in partnering with Elisa and the group to look at qualifications for staff, new hiring approaches. I'm particularly intrigued by what Elisa suggested about a rotating pool. That would be an interesting thing for us to do, I think. So I think we share all the same priorities, and we have a forum to work it out.
Super.
And I just want to add to Dr. Smith's comments that, the pandemic has really brought us together in a very different way in terms of our level of collaboration and partnership, and really out of the box thinking around creative ways to ensure that we're able to effectively deliver the services. And so I too just wanted to acknowledge our Behavioral Health Contractors Association, Elisa, and other leaders amongst our contract provider agencies who have really worked together very closely with us on all aspects that Dr. Smith just referenced with respect to contract flexibility, trying to come up with creative solutions during this time. So just wanted to add to that as well. Thank you.
Thank you, Sherry.
Appreciate that.
Supervisor Lee.
Thank you. Yes, just learning about this REDT, which stands for the Registered Alcohol and Drug Trainee. Apparently, they have different level 1 and 2 that I'm just reading up on. So, Alyssa, I guess what we have now, the counties, we do not have REDT, but we only have the CADC. Is that correct? The Certified Alcohol Drug Counselor. And you're basically suggesting that we should, just like the rest of the state, because the state level, that we should have this REDT as added so that more individuals should be able to get trained and qualified for this providing more service. Is that correct?
Yes, Mary Crocker-Cook, who's on the Behavioral Health Board, as well as being the Director of Alcohol and Drug Studies at San Jose City, has been concerned that her students aren't able to come into working in the system. And I think that there's ways, and our providers think there's ways to come up with guidelines that allow the RADT to come in and work in the outpatient setting, but adding additional requirements in terms of them being in a school program, having had a certain amount of training and experience, because in and of itself, an RADT, it's a minimal registration. The problem is there's no alternative to it. And so looking at using it with other requirements could really help us, increase the pipeline, better provide services, and still protect quality.
Nice.
Right. Thank you very much for that. And I guess the question I have is going back to staff is this something that you think our county could look into adopting in the future? Maybe a question for Dr. Smith or Sherry?
Yes, we can definitely look into it. We will look into it.
Thank you.
Thank you.
Thank you. And then the other question I have is regarding the admin red tape that should be reduced. So I'm going to throw the question back at Alyssa. What would you say are the biggest hurdles that providers are facing with our county in terms of some of those admin red tape that's causing so much angst, shall we say?
Let's just say that the state of California requires so much more documentation and paperwork when compared to all other states in the country. And obviously, documentation of services and having treatments plans and goals and following them is very, very important. But I think over the years, more and more requirements have been added at the state level to the point where we've gone beyond that breaking point. And that's why we'd like to partner with the county and also to work with behavioral health to review any kind of additional requirements and balancing the additional impact, positive impact they provide with the detrimental impact on workforce. And I'll just, take this moment to say, very much similarly to what Sherry and Dr. Smith said, that we have had, I think, just and built an outstanding working relationship. In my mind, evidenced by them inviting BHCA to be part of this. And we have found that we've been collaborative and able to problem solve together. And I look forward to continuing doing that.
Good. Thank you very much, Alyssa. And that's all question I have for now, President Osmond. Thank you.
Thank you. Supervisor Chavez.
Thank you. I want to say thanks for all the presentations. I want to go back to the beginning of this section on the single phone number, or the, how we get to a less confusing approach to getting services out. I'm really excited about that. And one concern I have is how long people even wait for the numbers that they do call. And I was wondering if there is an up-to-date analysis on the gateway phone number and how long people are waiting to get served when they call that number.
Sure. We actually have Bruce Copley here with us this evening, and he oversees our access call centers. And so perhaps, Bruce, you may want to comment on that.
Sure. Good evening. Good evening, Board of Supervisors, President. Yes, both for the mental health call center and for Gateway, we use the Cisco phone system that actually looks at the data as in terms of how long a caller has to wait before an agent picks the phone up, the number of drop calls, And typically on any given day, the average call time is about 2 to 3 minutes that an individual needs to wait. Now, there are obviously examples where it's much longer, where we've had people out with COVID and the actual number of individuals on the line just aren't enough to adequately handle the calls. One of the goals is to integrate the 2 call centers into 1 call center so that we have a larger group of call center agents. There'll be actually 25 individuals that can take both mental health and substance use calls. And we believe that that will eliminate any of the undue time that an individual needs to wait before the individual actually has an agent pick the call up. We're also looking to, in the budget, recommend 5 additional call agents be added to the team, again, to help address the call load that we have.
Thank you, Bruce. You know, a couple of recommendations that I would make. One is that, as Supervisor Simidian will recall, we had a similar challenge with the CAN Center, the Child Abuse Neglect line. And I think there would be a lot of value in talking to that staff about the changes they made relative to being able to be responsive to calls. And frankly, some of it was technology, but some of it was actually looking at new ways of scheduling, and also looking at new ways of assigning work. So that's one recommendation I would make. And the other is, I think as it relates to the point that people raised about wanting to be able to call 1 number for emergencies, the 211 or whatever that number ends up being, I think there is a lot of value in visiting our 911, you know, our emergency call center, because I think we have some of the experts frankly, in the country who are learning or know how to dispatch calls. What's unique about our dispatch center is many centers have, you know, a call for medical and a call for police. Our folks handle both. And I think there would be a lot of value in better understanding how they do their training. Now, it's completely understaffed and overwhelmed right now. But I do think that we have a lot of really good examples that we can pull from. I'll just share this too. Bruce, did you have a thought about that?
Yeah, yes, Supervisor. Actually, in looking at the 988 call, we have actually discussed with County Com and are having some meetings with them, asking them to look at what we're rolling out, and again, getting their expertise as to how we can make it the most efficient call line.
Good. Yeah, that would be, I think that's really helpful. I think the other thing I'm concerned about is that I'm concerned that not having the ability to triage the calls well and quickly as we're learning from them. You know, my nervousness all along is even about trust has been that I think we have to treat these numbers like we treat utilities, because there's a different benchmark for how 211, 311, and 911 operate, because they really do function at a much higher level, or the expectation is that they do. And so I want to make sure that whatever we're designing meets both those, you know, higher benchmarks, but also, frankly, we can learn from the triaging of the calls, because I think there's a lot we absolutely don't know yet. I think our MCAT and our the other team, I'm sorry, I'm forgetting all the acronyms.
MCRT.
Yeah, I mean, I think that those that we're still learning, like we're sending people to them and they're saying those are not the calls we take. So, you know, really refining all of that quickly so that we don't lose the public's trust in how we're able to respond with police and or without police, I think is just going to be critical, which is why I will again recommend the CAN Center, because I think that they've really, because they both take calls from police directly in the community, they have a very unique set of experiences. Thank you.
Thank you. Supervisor Simidian.
Thank you, Mr. Chair and colleagues. I want to return to the comments made by Ms. Elizabeth-Ginsburg and her request that we try and find a way to work together on paperwork requirements. And it may seem an unusual thing to pluck out of all this conversation, but it struck a chord with me because literally 20 years ago, when I was a new member of the California State Assembly, coming out of county government at that time, I introduced legislation simply calling for the creation of a task force to look at the reduction of paperwork for mental health in the county, in our county system. And the governor at the time, Governor Davis, vetoed the bill just to create a task force to study the issue. And it was made very clear to me as a new member of the legislature that there wasn't really any point in trying again. I'll just let it go at that. And I think, you know, it was interesting, painful, but interesting to me to hear Ms. Elisikoff-Ginsburg talk about, you know, it's only gotten worse in subsequent years. And let me just say, it was hell to wade through all those years ago. So I think it's worth taking another shot at it. Times have changed, understandings have changed, requirements have accreted over time, I think. And the point I want to underscore that Ms. Ginsburg made is this isn't just an abstract issue, and it's not just a question of, gee, that's annoying or a nuisance. There's a real opportunity cost, time and energy and money and talent that is spent on unnecessary or duplicative paperwork is time, energy, and money that isn't spent helping people who need our help. And as she also observed, if we've gotten to the point where people walk away from the work, even though they love the real work, but just can't take the bureaucracy anymore, that's a source of real concern as well. So I know we're not going to take formal action on this tonight, but I wanted to make sure that passing observation and request didn't get lost in the shuffle among the great many other important items. Thank you, Mr. Chair.
Thank you. Seeing no other hands, Sherry, we're going to go back to you. Thank you, Elisa.
Thank you, Elisa, and thank you, President Wasserman and members of the board. We just had one final slide, which was to highlight our next steps. We will plan to present our 9-month update regarding the management audit implementation progress to our Health and Hospital Committee and FGOC in March. So next month, or starting, I guess March starts tomorrow. And finally, we plan to return to the Board of Supervisors on April 19th with responses to the mental health and substance use as a public health crisis referral, as well as the behavioral health alternatives to incarceration referral. And so you will be able to expect a full response to those 2 referrals when we come back in April. And again, we just thank you for your time this evening and your commitment to this important area of behavioral health. And I'm not sure if there are any additional questions, but that ends our slideshow.
Thank you. I appreciate that. And members, I don't see Vice President Ellenberg.
Thank you. I do want to make some final kind of wrap up comments here and suggestions for April. And first of all, Sherry and team and Elisa, everyone that presented tonight, thank you so much. I know we directed you to do it, but I still just want to thank you for putting the time in to really educating all of us, to walking us through some really complicated systems, and for making it clear not only to our internal folks, but to the public that this is a priority. This is where we are digging in and learning. And when the report comes back in April, kind of what I'm thinking about, and this is really laid out in the mental health, the public health crisis referral that Supervisor Lee and I brought forward, is what do we really need to do transformational work here? I wanted to just think about moving beyond incremental steps to a real vision statement. What do we want our county to look like in terms of the way we meet mental health and substance use disorder needs? And when we know what the additional bed count is or additional facilities, how do we break that down? Who are the partners? where does the funding come from? Are these contractual issues? Are these construction issues, workforce issues? All of those pieces together in some, with really smart goals that we can measure, that we can make clear to ourselves and to the public that we are advancing here. I'm not looking for metrics, certainly as a way to penalize us on the way, but to really be able to hold each other accountable. And when we hit barriers, not to hide them, but to really discuss, why can't we get better here? Why can't we hire people? Why don't we have enough beds, so that we can all really partner together? A couple of other requests I have, when it's a little, and this may come more in the budget, I think it's really important for the board to understand the funding gaps between the state and federal funding and what our goals are, so that we really can evaluate whether, what kind of investment we should be talking about in terms of general funds, or whether we need a specified fund for more services. I know, and I agree with the priority of looking to state and federal funds before our own, but I just want to know what that delta is. And hang on one second, I did have something else. Oh, just a thought for Key, because I didn't ask a question or make a comment there. I really appreciated seeing the various housing strategies, and what I'm interested in there is just keeping an eye on how we distribute throughout the county. I absolutely support the scattered sites. I see that a lot of them are planned in D4 and along San Carlos, which may make a lot of sense, but let's be thinking the way we do with any other supportive housing that we're putting in, that we are distributing in a way that makes sense, and that we are working with our communities to make sure that we are going to be welcomed to the greatest extent possible. And lastly, we mobilized our county to fight COVID. We didn't turn it to a public health department and say, hey, you guys handle it. And I'm not expecting behavioral health alone to handle this crisis. When that report comes back, I'm hoping that we will see really a whole of county effort. That's, to me, really the definition of how you address a public health crisis. What is everybody's role in this, and how do we all support the end goals? So that is it. Thank you again so much to all the staff.
Thank you. Any other supervisors? I don't see any hands. Supervisor Chavez.
Thank you. I'm looking forward to the next couple of meetings, and also diving in a little deeper, both on reentry and children's family seniors, with different pieces of this. So very, very excited about that. I want to reemphasize what Supervisor Ellenberg said about, this is an emergency of incredible proportion. And I do see a lot of overlap here with our emergency for the people in our community who are homeless, and I don't think we can decouple those. And I agree that we're going to have a COVID-like focus on these really seemingly intractable challenges. And I want to just reemphasize something else that Susan said. The reason I keep asking for numbers isn't because I want to, say that someone's not doing a good job or embarrass anybody. It really is because these are so hard to hit. And, and I was reading the report, and the way I read the report, demonstrating the number of unduplicated services, that is a tremendous amount of work. And I do believe that we end up with people who have insurance using services that the county has because they have not fully built out their programs, and or they have barriers to accessing services. And so I do think one big body of work we're going to have to take a look at is what are our private sector partners obligated to provide and what are they providing, so that when we're looking at the critical care areas like EPS and even the new mental health facility, health and hospital at the Health and Hospitals campus at BMC, that we have enough capacity in the system to provide services to everyone. So I do think that's a body of research that that will need to be accomplished. And then the other thing I just want to really lift up is I really want an answer when we meet again about the people that we see on the streets who are really in high need of our support. And what is the plan for people who are seriously mentally ill? What is it? What are we, and if we do not have, if it's not IMD beds, which I understand we need to expand, then what is the gap in service? And maybe it's something we haven't thought of yet because we have so many more people who have serious addiction to drugs that are absolutely impacting their mental health, and it's becoming, an epidemic really. So I just want to know, like, who are the nonprofits that are doing the outreach? Is the outreach working? Do we have the appropriate placements? I think that's critical. Dr. Smith, I'm directing this one to you and not to Sherry, but you and I have talked for a number of years about the need to expand the public guardian. And I think we have a team over there very interested in playing a leadership role in these very hard to serve cases. And that's where our expertise is. So I'm going to be very interested in determining whether or not it's possible for us to, or appropriate to expand that part of the system. My sense is that it is, but I'm very, very interested in the thoughts of the staff. And then the detox beds. I think we need to really consider whether or not we're in need of more medical detox. And again, I think we're seeing kind of new things on the street that we haven't seen. I've lived here a long time, and I was telling Dr. Smith today that you really can't go anywhere in our community and not see people suffering. I mean, really suffering on our streets. This brings me kind of to the last big point that I would love to get a bigger discussion at. And Dr. Smith, I will be interested in where you think this needs to be heard. But I am really concerned about the way we assess whether or not someone is gravely disabled. And I understand the point you raised that we don't want to penalize people for being homeless. And the fact of someone's homelessness doesn't mean they're gravely disabled, but their inability to work, have steady, meaningful relationships, be able to clothe or feed themselves. And on top of that, they can't maintain where they live. To me, I want us to have, I want to better understand in a public session how that assessment is done and whether or not there is some obligation that we have to protect people who really truly can't protect themselves, and recognizing, the Law Foundation brought this up to us, that recognizing this isn't I'm not suggesting the county act unilaterally. I think this is something we should talk to our nonprofit partners about, and the Law Foundation, the public defender, and all of our teams, because the laws can't put us in a situation where we are contributing to human suffering so dramatically. And that's really where I think we are now. So, I'll be interested in getting feedback at whatever the appropriate forum is. And I too want to thank the staff and Elisa for really thoughtful information.
Dr. Smith.
I think Supervisor Chavez was just asking for future input, and I just wanted to encourage her that we will do that.
Thank you. So board members, I see no more of your hands raised. I'm going to speak last then. And just for the record, we have no members of the public wishing to speak. That said, I'm going to say, no one can do everything for everyone, but often in my years on the board, I go back to what's our mission? Public health, public safety. And if we don't have Elon Musk type dollars, if we put money out on a promise the Fed's going to reimburse us, if we do all these different things and we don't have enough money to do everything, I learned a great deal tonight. I still think our behavioral health department rocks. Can it do better? Of course. Any department in the county can. Okay. But as I listen to all of these needs expressed by our guest speakers, expressed by my fellow board members, almost all on Elisa's list. There were a few that didn't, but almost all on Elisa's list, almost all on Sherry's, almost all anything he would like to see cost more money. Paying people to stay, paying people to come over, paying floaters, whatever it might be. And so for myself, I'm going to remind myself that as we approve expenses going ahead and into the budget season, we can't do everything for everyone. We don't have unlimited funds, but our mission is public health and public safety. And I'm just speaking as one supervisor, the criteria I'm going to use as I look at things going forward. And even when I can justify something as public health or public safety, if there's other stuff that is more critical, at least for myself, I think we need to put whatever dollars that Jeff tells us we have available towards the most urgent. I agree with Supervisor Chavez completely in her last part about seeing individuals on the street clearly not in the right place of mind, who are out there at risk of themselves and need to be taken care of. Exactly how we do that, exactly how many more beds do we need, what we have, I don't know. But when I see citizens in conditions such as that, that really pulls at my heartstrings, that we need to find a way to do something better. And the fact it's so expensive to live in Santa Clara County, that's not our fault, that's just a reality. And it's tough to get people to apply to the Sheriff's Academy. It's tough to get psychiatrists to work in the jail. It's tough to get behavioral health people. It's really tough to get nurses to work here. They're being paid $250,000 to work in less expensive places. It's tough to compete, but I know with my board members and the administration and department heads that we have and all of our partners in the community, we will find a way to make a buck go as far as possible to pay for the most needed services. And that's where I'm at going forward. I just wanted to share that with everybody. All right. Oh, we now have two speakers. I had closed public hearing, but we were going to open up for these two speakers.
Our next speaker is Irvish Kumar Mehta. I am unmuting you. Please accept the unmute to begin speaking. Wait one moment. There you go.
Thank you very much to all the Board of Supervisors. I wanted to acknowledge all the points. However, I also wanted to mention that every individual, every professional, regardless of the experience that they have earned, when it really comes down to boiling down to the point that every penny and every move that they work towards the work that they do, it takes a lot of dig. And also I wanted to acknowledge that during this entire course of a pandemic to endemic, there were needs of a nurses, there were also a needs of a psychiatrist, there was a need of a specialist, there were needs of guard services, and all these individuals, they represent the different field, though when the need arises, they come together and help out. But what becomes more important is that when actually the help is needed and it's unavailable. So it is equally important that the funding which is being allotted for the behavioral health mental health, also for the special facilitations that are getting opening within the Santa Clara County, that funding be assigned to that for that specific purpose. And we also we also do not know that when the actual need arises, just like COVID-19, and then we need the actual staff to take care of the things. So it is important to also keep a buffer spendings along with that. Thank you very much to Board of Supervisors.
Thank you, Irvish.
Next speaker is Uday Kapoor. Please accept the unmute to begin speaking.
Thank you very much. Thank you for the time. I'm glad that we got an opportunity to talk. I know many of you, and thank you for everything that you're doing. It was a very nice time the last few hours, and I congratulate you for everything that you're doing. There's one aspect, of course, as you know, I have been very passionate about the housing issues as part of NAMI, and I applaud Key and everyone else that have been working very hard to provide additional housing. So one aspect that I wanted to talk about is we talk a lot about substance use and also mental illness as co-occurring or issues, but we don't talk about people with developmental disabilities and mental illness. And that's an issue that is also very prevalent. It is not recognized as such so much, but it is. And so I have actually organized a symposium with some of the people from the regional center and the state, and we are talking about bridging the gap. We had a symposium 6 months ago. We're going to have another symposium shortly. So that's an area that I really would urge people to have training to the clinicians so they can understand the additional need that some of the folks have for people with developmental disabilities. So again, thank you so much for everything that you're doing.
Thank you.
And that concludes our speakers.
Thank you. And with that, I'm going to call for adjournment of our meeting. Have a good rest of the evening, and we'll see you all soon. Good night.
Thank you.
Recording stopped.